So we'll get started in about 3 minutes. Okay, so we'll get started. Good morning, everyone. Thank you all for joining us. I would like to welcome everyone to the NGV Department of Neurology July 2021 Grand Rounds. I want to remind everyone that your audio will be disabled during the webinar, but there'll be an opportunity at the end of the lecture to make any remarks or comments or questions that you may have. And you can either tell me that you want to speak either through the chat function or ask questions through the Zoom Q&A feature. So now, without further ado, I have the honor of introducing today's Grand Round speaker, which is Dr. Sahar Zafar. Dr. Zafar is a board-certified neurointensivist and clinical neurophysiologist who serves as an assistant professor of neurology at the Harvard Medical School. She also serves as the director of the Mass General Brigham HMS Neurocritical Care Fellowship, the associate medical director of the NGH Neurosciences ICU, and a trusted mentor to many of the neurology residents and epilepsy and neurocritical care fellows, both past and present. Her academic interests are aimed at improving the neurologic outcomes in critically ill patients with acute brain dysfunction and seizures, with published research that has been focused on EEG monitoring in the ICU and identifying electrographic patterns in the critically ill as potential targets for treatment and as predictors of neurologic outcomes. She's received the K23 award to investigate the safety and effectiveness of anti-epileptic drugs in patients with acute brain injuries, which I'm delighted that she could join us today to tell us more about. So I will pause here and allow Dr. Zafar to take over for her talk.
Thank you for having me. Very excited to be here and to share some of the work that I'm doing. So I have, I was asked to share this for everyone. And these are my disclosures. So the objectives, what I will be reviewing is the prevalence of common ICU EEG patterns in critically ill patients, assess the impact of seizures and other abnormal EEG patterns on outcomes, and then look at the data or evidence we have on the safety and effectiveness of anti-seizure treatment strategies. So to begin with, this is just an overview of EEG utilization over the last decade or so, which has seen a significant increase in EEG utilization in acute brain injury and critically ill patients for the primary indications of seizure detection, monitoring depth of sedation, as well as prognostication. And this increase is not only within the US, but global trends have also seen an increase in EEG utilization. And of course, with increasing EEG utilization comes an increased awareness of the prevalence of seizures and other periodic and rhythmic patterns in critically ill patients. These can be seen in up to half of ICU patients who are comatose or have altered mental status. Periodic and rhythmic patterns that don't meet the qualifying definition for seizures, but are suggestive of cortical irritability are now being increasingly recognized. In fact, I think if many of you look at our reports for patients in the ICUs that are being monitored, more often than seizures, there are reports of periodic and other rhythmic patterns. And so, of course, there's been a growing interest in what is the diagnostic and prognostic significance of these patterns. And for this reason, the American Clinical Neurophysiology Society proposed a standardized nomenclature for these patterns, which is now being applied not only in the research realm, but also clinically, which I'll review first before proceeding with the data on how they relate to outcomes. So just as an overview, these periodic and rhythmic patterns, there are two main terms that define them. The first is the region. They can be generalized, lateralized, bilateral independent, or multifocal. And then the second main term is the pattern type. Periodic discharges are sharp discharges that occur periodically. Rhythmic delta are slow waves that occur rhythmically, and then of course spike and polyspike and wave discharges. So going through just a few examples of these patterns, this is an example of lateralized periodic discharges. To orient everyone, this is a bipolar montage, left temporal, right temporal chain, left parasagittal and right parasagittal. And over the left hemisphere, we see these sharp waves occurring once every other second, so at about 0.5 hertz. And this is a classic example of what lateralized periodic discharges would look like on EEG. Here is an example of bilateral independent periodic discharges, again, left and right parasagittal regions, and we see sharp waves occurring about once per second, but occurring independently over the two hemispheres. And this would classify as bilateral independent discharges. Contrasting this to these discharges, these are what we would classify as generalized periodic discharges. Again, this is a bipolar montage, left and right temporal chains, left and right parasagittal chains, and we see generalized sharp waves occurring about once per second. And this is a classic example of generalized periodic discharges. Finally, this is an example of lateralized rhythmic delta activity, so slow rhythmic waves that are occurring over the right hemisphere. These are distinguished from the sharp discharges that we're seeing in our prior EEGs. And finally, here is an example of similar rhythmic delta, but more generalized. So this is another bipolar montage, left and right temporal, left and right parasagittal chain, and we see generalized rhythmic delta activity. When these patterns occur in association with a stimulus, which could be examining the patient, turning the patient, even walking into the room, we refer to them as stimulus-induced periodic or ictal discharges. And I'll talk more about the prognostic significance of these in just a little bit. So when do we see these patterns? Not surprisingly, the lateralized patterns, lateralized periodic discharges and rhythmic delta activity tend to be seen more commonly in patients that have an acute structural brain injury, so traumatic brain injury, tumor, stroke, infections, etc. While the more generalized patterns, such as the generalized periodic discharges and generalized rhythmic delta activity, tend to be seen more common in patients that have a diffuse process, so anoxic brain injury, toxic metabolic encephalopathy. Those are the etiologies, and we see the generalized patterns more often. However, this is not a hard and fast rule. We can certainly see generalized patterns in patients with an acute structural brain injury, especially if they have a metabolic derangement. Similarly, we can see lateralized patterns in a patient with a diffuse metabolic process or sepsis, more often if they have an old brain injury and old structural injury. But the question really is, with us seeing these patterns more and more, is what is the significance of these patterns? Are they suggestive of secondary brain injury? Are they an epiphenomenon? Are these patterns ictal? Are they interictal? How are they related to seizures? Do they result in secondary brain injury, and how do they impact outcomes? And there have been many small focused studies on different disease subgroups and cohorts that have tried to answer these questions that I will go through over the next few slides, along with some of the more recent and larger studies that we have done. So with regards to association with seizures, this is probably the largest study looking at these patterns. It was a study of 4,000 patients done by the Critical Care EEG Monitoring Research Consortium, where they looked at the risk for seizures in association with these patterns. And what they found was that lateralized patterns, whether they're periodic discharges or rhythmic delta activity, are significantly associated with seizures. Similarly, generalized periodic discharges are significantly associated with seizures. However, generalized rhythmic delta activity is not significantly associated with seizures, and so is less like, and by seizures we mean clinical and electrographic seizures, either before or after. And so when we see generalized rhythmic delta activity more and more now, we believe this to be a more benign pattern compared to the other periodic and rhythmic patterns. The other finding was that the higher the frequency, especially at a cutoff of 1.5 hertz or more, and the higher the prevalence, so if more than 50% of a recording is occupied by these patterns, there is a greater risk for seizures. As you can see here, these patterns have a higher risk for seizure, and this risk increases as the frequency of all these patterns increases. So this was one of the largest studies looking at what the risk for seizures is with these patterns. Then what evidence do we have for secondary brain injury? And again, there have been small cohort studies in different disease subgroups that have tried to answer this question. To begin with, I just wanted to summarize what we do know or what is well established for generalized convulsive seizures. And we know that for these patients in the acute phase, there is both a systemic compensation as well as the brain autoregulation. And the systemic compensation results in sympathetic overdrive, where cardiac output, blood pressure, blood glucose, blood lactate all sort of increase in response to seizures. And brain cerebral metabolism and blood flow is maintained during this period so that brain oxygenation and glucose levels are maintained. However, beyond a certain point, if seizures persist and are not treated, these compensatory mechanisms start to fail, both the systemic compensation as well as cerebral autoregulation. And systemically, we see cardiorespiratory collapse, electrolyte imbalances, as rhabdomyolysis, and organ failure. And within the brain, we see that there is drop in brain tissue oxygenation, drop in brain glucose, and increase in brain lactate pyruvate ratios, suggesting secondary brain injury and increased brain metabolism. So the question is whether the periodic and rhythmic patterns result in a similar form of metabolic stress. And so some of the studies that have looked at this have looked at different mechanisms of assessing metabolic stress. This was a study looking at PET correlates of periodic and rhythmic patterns. What we know is that generalized convulsive seizures and status epilepticus is associated with PET hypermetabolism. And what the authors found in this study is that periodic discharges have a similar hypermetabolism similar to that seen in association with generalized convulsive seizures, thus hypothesizing that these patterns are associated with increased brain metabolism and potentially secondary brain injury. Again, this is a small cohort study, so it's hard to draw a causal inference, but clearly there was an association that was seen with these patterns. Similarly, this is work that was done by the Columbia group, and they looked at brain tissue oxygenation in association with periodic discharges measured on depth EEG monitoring. And what we found was this is time point 0, where high frequency periodic discharges are seen on depth recording. And in association with these high frequency periodic discharges, they saw a significant reduction in brain tissue oxygenation. Notice that the brain tissue oxygenation starts to fall even prior to the onset of the periodic discharges. However, the reduction is significantly higher after the periodic discharges start. So it's possible that the brain injury, decreased oxygenation results in these periodic patterns, which then subsequently result in further brain injury, sort of creating a vicious cycle. Again, this is a small cohort study. So it's, one cannot draw a causal inference, but at least there is an association that is evident with these patterns. In the similar vein, but in traumatic brain injury patients, this study looked at periodic patterns and then brain metabolism as measured by brain glucose and the lactate pyruvate ratio. And what they found in this cohort of TBI patients, that during epochs where periodic discharges were noticed on the EEG, there was a drop in brain glucose and an increase in the brain lactate pyruvate ratio. And during non-ictal epochs, when there were no periodic discharges, there was a resolution, an improvement in the brain glucose, and a reduction in the brain lactate pyruvate ratio. So again, suggesting that there is some secondary brain injury, increased brain metabolism that is seen in association with periodic patterns. Another study, this was done by Jen Kim, one of our former fellows and residents, who looked at the association of these epileptiform patterns and development of delayed cerebral ischemia in subarachnoid hemorrhage patients. And what we found was, again, these patterns are, other than GERDA, which does not seem to be associated with a delayed cerebral ischemia, the lateralized patterns and periodic discharges are significantly associated with development of delayed cerebral ischemia. And not only are they associated with delayed cerebral ischemia, these patterns tend to, are almost always seen prior to the occurrence of the delayed cerebral ischemic event. Again, suggesting that there is some association, or there may be some link with secondary brain injury as manifested by delayed cerebral ischemia. So, again, these are all small studies. You cannot draw causal inference from all these smaller studies. However, they all have similar findings where all these patterns seem to be associated with secondary brain injury or increased brain metabolism measured via various different modalities. So we know that there's an association with seizures. We know that there's an association with increased brain metabolism. The next question is, what about outcomes in these patients? And this is just a summary again of many small studies that have looked at the association with outcomes. Similar to the prior data with regards to seizures and secondary brain injury, generalized rhythmic delta activity tends to be, is not significantly associated with worse outcomes. However, the other patterns, lateralized periodic discharges and rhythmic delta activity, as well as generalized periodic discharges, do not only have a higher association with seizures, but are also associated with a greater risk for mortality and worse functional outcomes. This was work looking at subarachnoid hemorrhage patients, where the goal was to assess whether the actual burden, the quantified burden of seizures is associated with worse outcomes. And the authors calculated the seizure burden per hour for these patients. On the x-axis, here is the number of hours spent in seizures. And on the y-axis is the probability of poor outcome, which was defined as MRS of 4 to 6 at 3 months and then a year. And what they found was that increasing burden of these of seizures was associated with an increased probability of poor outcomes. Subsequent to this, we tried to determine whether not just seizures, but these other periodic and rhythmic patterns, LPDs, GPDs, are associated with worse outcomes in subarachnoid hemorrhage patients. And so in our cohort of 130 subarachnoid hemorrhage patients, we quantified the daily burden of epileptiform patterns, which we described as lateralized and generalized periodic discharges and lateralized rhythmic delta activity. On the x-axis here is the number of days of recording. All our subarachnoid hemorrhage patients are typically, high-grade aSAH patients are typically monitored for about 10 days. And on the y-axis here is each individual patient. The color codes, the reds are patients who had lateralized periodic discharges and rhythmic delta activity and generalized periodic discharges. The blue shows generalized rhythmic delta activity. and gray is absence of any of these periodic patterns. And the darker the color means the higher the burden. So the darkest red signifies more than 90% of the recording occupied by these patterns. And what we found was that patients that had a higher burden of these epileptiform patterns, they were more likely to have worse functional outcomes at 3 months, even after adjusting for disease severity, including the subarachnoid hemorrhage disease severity scores, critical illness disease severity scores. In fact, we looked at increasing burden. So this on the x-axis here is the 24-hour epoch that had the highest concentration of these patterns. And what we found was that as the burden or the maximum daily burden increased, the probability of poor outcomes increased by almost 40% in this cohort of patients. And poor outcome again here was functional outcomes at 3 months. So next we actually looked at a large cohort of ICU patients. This is 2,000 patients admitted to ICUs at MGH, all adult patients who underwent at least 16 hours of continuous EEG monitoring. And our goal was to determine the association of EEG findings with outcomes at discharge, which we measured using the modified Rankin scale. And we evaluated 3 different measures of epileptiform burden. And again, epileptiform patterns here are lateralized periodic discharges, generalized periodic discharges, lateralized rhythmic delta activity, and seizures. And we assessed the burden seen within the first 24 hours of recording, the peak burden, which we define as a 12-hour sliding window that had the highest burden within the first 72 hours, and then the cumulative burden in recording. I showed you what we did with our subarachnoid hemorrhage patients. Similarly, this is all our 2,000 patients. We developed, for this study, we developed an automated tool for annotating EEG data and annotated EEG patterns down to every second for all these patients. On the y-axis here, all 2,000 patients. On the x-axis, the first 24 hours of recording. This is just a blown-in version of the prior figure. So on the x-axis, on the y-axis, we're showing the first 200 patients. And on the x-axis is the first 3 hours of recording, and the color code signifies the pattern type. So orange and red. Red is seizures, orange is LPDs. The yellows that we see are generalized periodic discharges. Green is lateralized rhythmic delta, and blue is GERDA. And other just means either normal EEG or presence of artifact. It could include generalized or focal slowing, but just did not have any of the epileptiform patterns of interest. So after annotating and quantifying the burden in these 2,000 patients with about 11 terabytes of EEG data, we used machine learning to determine the independent association of the different measures of burden with outcomes in these patients. And again, we adjusted for disease severity. This included their critical illness severity, including their Apache 2 scores, their comorbidities, presenting GCS, age, as well as the main underlying diagnosis. And what we found was that of the 3 measures of epileptiform burden, the first 24-hour burden, the peak burden, and the cumulative burden, the peak epileptiform burden, which is again the 12-hour window that had the highest concentration of these patterns, independently predicted poor outcome at discharge. We further stratified the model based on time of measurement of this peak burden to discharge, breaking it down to less than 5 days, 5 to 10 days, and greater than 10 days from the last EEG measurement to the time of discharge, and found that the association of peak burden with outcomes is independent of the time between the peak burden is measured and the patient is discharged, whether it's a short stay or a long stay. And here we show that the model estimated risk of poor outcomes closely matches the observed poor outcomes with a very small calibration errors. We then looked at, similar to what we had done with the subarachnoid hemorrhage patients, increasing the peak epileptiform burden from 0, which means no epileptiform burden in that 12-hour epoch, to 100%, this is the entire 12-hour epoch being completely occupied by epileptiform burdens, increase the probability of poor outcomes by about 40%. Again, independent of the time interval between the time we measured the EEG burden to the actual time of discharge. Finally, we tried to see if this finding holds true across different disease categories. We looked at patients who had an acute structural brain injury. We looked at patients who had hypoxic ischemic encephalopathy, patients that presented with acute seizures or status epilepticus in the absence of a structural brain injury and in the absence of hypoxic ischemic encephalopathy, and then patients that had a systemic illness, which could be respiratory failure, cardiac failure, acute kidney injury, but in the absence of any acute structural brain injury, HIE or seizure. So these are all mutually exclusive. And again, found a similar relation where increasing peak epileptiform burden from absent to 100% of recording increases the probability of poor outcomes, independent again of the time of measurement of the burden and the interval between the EEG monitoring and the time of discharge. So, with having said all of that, knowing that these patterns are associated with seizures, associated with secondary brain injury, associated with poor outcomes now that we, demonstrated not only in smaller cohorts, but also across the larger cohort. The next question is there evidence to support treatment of these patterns with anti-seizure treatments? And unfortunately, the quality of evidence is poor. It's something that I hope to work on and I am working on. There are no randomized controlled trials on how and when to treat these periodic and rhythmic patterns. And in the absence of good quality data, seizure medications are frequently started in response to these patterns. And of course, without any treatment guidelines, there's considerable practice variation. And anti-seizure medications themselves are not risk-free. Up to 80% of patients that we see in our clinics present with seizure medication side effects, including cognitive slowing, gait instability, sedation. So there is a risk-benefit ratio that has to be taken into consideration. The challenge, however, in designing a randomized trial to understand these patterns should be treated or not is one, the clinical complexity of these patients. They're ICU patients, multi-system failure, multiple organ derangements with multiple organs, and trying to develop stringent inclusion and exclusion criteria can be challenging for these patients. Second, the patterns themselves have a dynamic nature. They fluctuate in frequency, prevalence from day to day, from hour to hour, and understanding when to enroll a patient, at which time to start the seizure medication is also challenging. And so as a first step, what we are trying to do is utilize real-world observational data, perform comparative effectiveness studies and experiments that leverage the practice variation that we see in the treatment of these patterns that can then provide us signals and hypotheses that can subsequently be studied in randomized controlled trials. So as a first step, we looked at patients with subarachnoid hemorrhage patients. This is similar to the figure that I've shown before. On the x-axis here is the days of recording, and the y-axis is individual patients. And again, the reds denote periodic and rhythmic patterns and seizures. The darker the color, the higher the burden. The blue denotes generalized rhythmic delta activity, and the gray is absence of any epileptiform patterns. And of course, we see that patients that have these epileptiform patterns, especially a higher burden, are more likely to be treated. However, there is a good number of patients that have these patterns, in fact, even have high burden, that don't end up getting seizure medications. And so we try to design experiments on these subarachnoid patients, leveraging this practice variation. And in the study, we looked at subarachnoid patients who were adults, had at least 24 hours of EEG, and had EEG that started within 4 days of admission. We stuck to the 4-day window because we know that the highest risk for developing epileptiform patterns in these patients is in that 4-day window, and extending that window would decrease the homogeneity of the population. We excluded any patients that had a diagnosis of epilepsy or acute symptomatic clinical seizure, essentially any indication for anti-seizure medications outside of EEG findings were excluded. And then we defined our exposure as continuation or reinitiation of seizure medications. So at MGH, all aneurysmal subarachnoid hemorrhage patients receive seizure prophylaxis with Keppra until their aneurysm is secured. And typically the aneurysm is secured within the first 24 hours, immediately after which seizure medications are discontinued. So our exposure was defined as either continuation or reinitiation of seizure medications after the aneurysm was treated and after the first 24 hours of EEG monitoring were obtained. And we restricted this exposure window to the first 10 days of admission, given that's how long we monitor our patients for, and that is the highest risk, that's the time period at which patients are at highest risk for developing these patterns and being treated. Our outcome was 90-day mortality as well as functional outcomes. Of course, having stringent inclusion and exclusion criteria does come at the cost of decreasing our sample size, where 40 met the criteria for exposure and 54 were not exposed to AED treatment. We then use propensity methods to adjust for confounding and confounding by indication in these patients. So we developed propensity scores that predicted the likelihood of being treated with seizure medications, and also or with variables that are known predictors of poor outcome. And all the measures that were used to build the propensity scores were measured prior to the exposure to AEDs. And these variables included baseline demographics, baseline disease severity scores, critical illness severity measured by the Apache 2 score, comorbid conditions, as well as the presence and burden of epileptiform patterns in the first 24 hours of recording. So here I'm showing the Kaplan-Meier and propensity adjusted survival curves. And we found that after adjustment for propensity, there was no significant difference in mortality amongst patients that were treated or were continued on seizure medications in response to EEG findings versus those who were not. We then looked at functional outcomes, and again here on the left is the unadjusted curve, and on the right is the propensity adjusted curve. And what we found was that patients that were treated with seizure medications beyond that initial period or continued on seizure medications in response to EEG findings were more likely to have worse functional outcomes even after propensity adjustment. So adjustment for the indications for treatment as well as adjustment for predictors of poor outcome. And in a sub-analysis, we found that high intensity treatment defined by use of multiple seizure medications at high doses and seizure medications along with anesthetic uses were even more significantly associated with poor functional outcomes as well as with mortality. So in our cohort of subarachnoid hemorrhage patients, we found that continuation or increase of seizure medications, particularly high intensity treatment, was not associated with a survival benefit and was associated with worse functional outcomes. Of course, this is a small cohort study. There is still a question of residual confounding, although we saw from the movement of the crude to adjusted curves that our propensity scores perform well. It's hard to draw causal inference, but the findings do show that we need to understand and take into consideration the harmful effects of these epileptiform abnormalities and also the risk of adverse effects. And treatment probably lies somewhere in between aggressive treatment versus no treatment at all. We then tried to look at a larger cohort of patients. These are all patients admitted to ICUs across MGH, again, adult patients. We excluded cardiac arrest patients, and we tried to understand whether escalation of seizure medications after EEG initiation is associated with outcomes. So find exposure as patients that received at least 24 hours of EEG, followed by a treatment escalation. So the AEDs had to be escalated or increased after the 24 hours of EEG and while the patients were still on continuous EEG monitoring. And we restricted the exposure window to the first 7 days of admission, again, to increase homogeneity of the cohort. And our outcome measure here was discharge mortality. And here what we found was that across all patients, this was a total of 1,000 patients who were exposed to continuous EEG followed by treatment escalation. When seizure medications were escalated, the odds, escalation of seizure medications after EEG showed a lower odds for discharge mortality. However, when there was escalation of seizure medications along with anesthetic use, and the anesthetics could be used for seizure control, for ICP management, for sedation, these patients showed increased risk for discharge mortality. Similarly, in our cohort of patients that were admitted with seizures or status epilepticus, CEEG use followed by anti-seizure medication escalation alone in the absence of anesthetic use was showed lower odds for discharge mortality. However, when we looked at anti-seizure medications along with anesthetics in these patients had higher odds for discharge mortality. Among neurologic patients who did not have seizures, so this is our cohort of patients that have periodic and rhythmic patterns who underwent EEG monitoring, seizure medication escalation, regardless of whether or not these patients received anesthetic medications, showed higher odds for discharge mortality. And then in the altered mental status group, the odds for discharge mortality were not significantly different across those who were treated with seizure medications, with or without anesthetics. So, of course, the challenge here is that treatment of these patients, use of anesthetics itself is contingent on how severe the underlying illness is. And so while we use machine learning to address or adjust all the underlying disease severity scores as well as comorbid conditions, there is still a risk for confounding using observational data. However, based on our findings in this cohort, as well as in subarachnoid hemorrhage patients and other smaller cohorts, we're seeing, we hypothesize that EEG-guided lower moderate intensity treatment with anti-seizure medications may improve outcomes in ICU patients. However, aggressive treatment with multiple seizure medications as well as anesthetics may not improve outcomes, and we need to understand the risk-benefit ratio in these scenarios. So one of the questions, there's growing data on trying to use other data points or other biomarkers and ancillary testing that can help guide treatment, and that perhaps just chasing the EEG itself on its own is not sufficient, and it should be a composite of what is happening clinically, what the EEG shows, and then using other ancillary testing or data that can provide us evidence on whether or not there is ongoing secondary brain injury with these patterns, and combining all of these to help guide treatment. So just an overview of some of the data that we have on ancillary testing. Again, there haven't been large randomized trials showing which one of these testing modalities are the best to use. But clinically, we are, and I know a lot of centers are starting to use additional data to help guide management. So MRI is one of the modalities. We know that in patients with seizures or status epilepticus, MRI often shows diffusion restriction in a cortical fashion, particularly from the onset side of the seizures as well as in the hippocampi. And there's some data to show that similar findings may be seen in association with periodic and rhythmic patterns. And so if there's a question on whether patterns should be treated or not be treated, and the patient is comatose, there's not enough clinical data to follow, this could be one of the modalities that can be utilized to help guide treatment. Similarly, PET scans, as work done by Aaron Struck, one of our former fellows, and Eric Rosenthal, one of our colleagues, looked at the utility of using PET scans in these patients. This is an example of a 25-year-old patient who presented with generalized convulsive status, was treated Her seizures resolved, but she continued to have lateralized periodic discharges on her EEG and was encephalopathic. And the question came whether, these patterns should be treated, should we chase these LPDs or not? And so the treating team performed a PET scan, and what they found was hypermetabolism seen corresponding to the area of LPD. So this is the left temporal chain where we're seeing the LPDs, and here on the left temporal area, we see an area of hypermetabolism. So combining the clinical picture of encephalopathy, the EEG where there is LPDs present, and the PET findings, the treatment team pursued increasing seizure medications and saw an improvement in the patient's clinical status and EEG. Similarly, invasive monitoring can be used when appropriate. So we are currently using invasive monitoring in our severe TBI patients. And here's an example of the utility of invasive monitoring in a subarachnoid hemorrhage patient. This was a 50-year-old patient who presented with a subarachnoid hemorrhage. And after treatment of the aneurysm, the patient remained comatose post-operatively. And on their EEG, the treatment team found rhythmic delta slowing or lateralized rhythmic delta activity over the left hemisphere. This patient also had a depth electrode, and we can see the depth electrode recordings right here at the bottom of our screen. And in conjunction, when rhythmic delta was seen over the left cerebral hemisphere, concomitant periodic discharges were seen on the depth recording. And combining all the data, the treatment team decided to treat the patient, reinitiate Keppra and increase the Keppra levetiracetam dosing. And what they found after treatment was there was an improvement on the scalp EEG, resolution of the periodic discharges on the depth electrode, and overall improvement on the EEG for the patient, as well as a clinical improvement in their exam. So just another example of how combining different data points can help manage these patients. So while we're still waiting to get more data and perform a randomized control trial, I like this figure because it's a good approach on how to pursue these patterns. So if someone has IIC stands for ictal-interictal continuum, or any of these periodic and rhythmic patterns, on EEG, when you see them and assess them, the first question is whether or not there is a clinical correlate. The clinical picture is the key. If there is a clear clinical correlate, then you can consider AED treatment. If there is no clinical correlate, then we use the pattern type, location, frequency, prevalence to help guide treatment. If there are lateralized patterns and they're low frequency, low prevalence, low burden, we know that in those patterns are less likely to be associated with seizures, less likely to be associated with secondary brain injury, less likely to be associated with worse outcomes. It's reasonable to watch and wait and see how the clinical picture evolves and how the EEG evolves. If the patterns are high frequency, more than 2 hertz, high prevalence, more than 50% of the recording is occupied by these patterns, they're waxing, waning, fluctuating, then we know that those are the patterns for which we have data that they're associated with worse outcomes, with seizures, with secondary brain injury, and it's reasonable to consider a treatment trial. If it's a generalized pattern or generalized periodic discharges, note generalized rhythmic delta activity is not in this table, as we tend to, we found that it tends to be a more benign pattern and it's reasonable to observe it unless, the clinical picture says otherwise. So for generalized periodic discharges, again, for a generalized pattern, the first question is there an associated severe metabolic derangement? Is the patient uremic? Are they hyponatremic? Is there BUN 100? Are they septic? Trying to understand whether there are major metabolic derangements. And if there are, and it's a low frequency pattern, it's not evolving, it's not fluctuating, it's not high prevalence, it's reasonable to watch and wait again. And if there's worsening, then we can consider treatment. If there's no metabolic derangement, again, we use sort of, the pattern itself, the frequency, the prevalence, the burden to determine whether it's reasonable to watch and wait a bit versus initiate treatment. And then the treatment itself, again, there's no data here. And so we generally guide based on patient comorbidities. If the patient is in the ICU already intubated, you can try an AED that is more sedating. If it is an older patient, DNR, DNI, not intubated, using a less sedating medication may be a better alternative. And then once treatment is initiated, we need to follow not just the EEG, but mainly the clinical exam. Assess for clinical improvement as well as EEG improvement. And often the EEG may improve before the clinical improvement, given the effect of the AED itself in quieting down the EEG. So observe them longer to see if there is a clinical improvement. And if there's no clinical improvement or if there's no EEG improvement, the patterns are persisting, before adding on medications or trying more aggressive treatment strategies, it may be reasonable to consider using some form of ancillary testing, either PET scan or MRI scan, if they have a depth electrode, utilizing that and trying to combine all the data points to determine whether or not treatment strategies need to be escalated or use more aggressive treatment strategies. So just to summarize, seizures, periodic rhythmic patterns are very commonly seen in ICU patients. High burden, high frequency patterns are associated with increased risk for seizure, secondary brain injury, and poor outcomes. But in the absence of clear-cut treatment guidelines, treatment really should be geared first and foremost towards the clinical presentation and what the clinical picture is, and then followed by the pattern type, frequency, burden, and where applicable and possible, using ancillary data to help guide management. And of course, larger studies are needed to determine the risk-benefit ratio for treatment. And looking forward into future directions, the ideal would be to do a randomized controlled trial and likely using composite endpoints, not just the EEG itself, but combining EEG with clinical exam, biomarker improvement, using these composite endpoints to identify which patterns should be treated. And then at the same time assessing what the overall safety of these treatment strategies are. One of the things that I'm currently working on, we're working on developing a multi-center registry to look more prospectively into long-term cognitive and functional outcomes, epilepsy risk, and seizure medicated related side effects in these patients. And so we're trying to develop, follow these patients on an outpatient basis for a prolonged period of time, because another one of, so the acute scenario is one thing, and that's what I focused on. But most of these patients, when they do get started on seizure medications, end up being discharged on seizure medications. And then in the outpatient setting, depending on who sees them or where they follow up, often they come to us are referred to us from other sites and go back to smaller community centers. There is hesitancy in weaning off these medications, exposing these patients to seizure medication-related adverse effects. So that's sort of the next step as well, addressing how to manage not just acutely, but also in the long term. With that, I come to the end of my talk. I want to first thank Dr. Westover, who has been my mentor all this time, and without whom I couldn't do any of the work that we've talked about. Eric Rosenthal, who is a mentor and colleague and who's worked with us on almost all of this work, Dr. Roseanne, Dr. Cole, and then Jinjing, Wendong, Rajesh, and Hauchi are all postdocs in our lab who've been tremendously helpful in getting this work done. Thank you.
That was a great talk. Thank you so much, Dr. Zafar. There is a question in the chat, so So from Kevin Staley, in the submitted study of subarachnoid hemorrhage outcomes versus AED treatment, did you stratify outcomes by either which AED was used and the effect of the AED on the epileptiform activity?
So we didn't, so the way we stratified was, so initially our AED exposure, we included all AEDs, and for the most part it's levetiracetam, but phenytoin, lacosamide, sort of everything, it was just a composite of all AEDs. But we did end up stratifying and did a sub-analysis based on treatment intensity. We defined low treatment intensity as low to moderate dose of levetiracetam, phenytoin, all the various different AEDs that we commonly use. So low to moderate dose single AED. And in our low intensity treatment, all patients received levetiracetam at doses of 2,000 milligrams per day or less. And in that subgroup, we found again that the treatment was associated with worse functional outcomes, but not associated with mortality. The high intensity group had patients that received multiple AEDs, and then patients that received multiple AEDs with anesthetics. So we didn't break down different AEDs within that group. And within that subgroup, we found that the high intensity treatment was associated with both worse functional outcomes and also higher mortality after propensity adjustment. And then with regards to effect on epileptiform activity, we did look at that. And we found that patients that were treated with AEDs, they had resolution of the epileptiform or improvement in their epileptiform activities earlier than patients who did not receive AEDs. However, those who were not continued on treatment did also have resolution with time. There was about a 24-hour to 48-hour difference in the time to resolution. Again, these are small numbers, so it's hard to draw any conclusions, which is why I didn't bring it up here. But we did see that those who were not treated eventually did have resolution, but just after a delay.
Do you think that part of, since a lot of the studies were looking at modified ranking at like a 3 or 6 month mark, and you touched briefly at the end about how essentially patients aren't followed for de-escalation in therapy, if like that had an impact, or if you believe that has an impact on their overall modified ranking and their outcome, especially if people have had changes in their EEG without addition of AEDs with time?
No, and that's a great question, and that's sort of one of in that paper that is under review. That was one of the hypotheses that we proposed, that almost all those patients that were continued on AEDs in acutely were also discharged on AEDs. And so the question arises, did they just have worse outcomes because they were having seizure medication related adverse effects? And that's why they were doing worse. And so I think when we do, hopefully once we get to the point of doing, the randomized trial, the question would be doing a short course of treatment while they're in the hospital, acutely treating them, and then rapidly weaning them off, so that, to minimize AED-related adverse effects on discharge. That's one of the future directions. Another future direction, I think, also is the MRS in itself. It's a functional outcome measure, and what we don't really capture in the MRS, and what we hope to capture now with all our future work, is really looking at cognitive outcomes, especially since AEDs have cognitive side effects, and then health-related quality of life outcomes, which may reflect even more, how patients are doing after having the acute brain injury and being treated with these seizure medications.
Great. Brian Edler also agrees. Great talk.
Thanks, Brian.
If anyone have any additional questions for Dr. Zafar? Or want to make any remarks, I can also unmute people if needed. Okay, I think we'll give it another minute till 9:55 so far. Many compliments. Okay. Well, I think that's it for today. That was great. Thank you so much for joining us. That was an awesome talk.
Thank you, everyone.